It's Thursday morning. We're still feeling good, guys? Excellent. It's almost coming to the end of the week, which is a bit sad. Still, it's okay, it's okay. Still plenty of time, don't worry. But I will just quickly give a heads up about the closing party tomorrow evening. So, love to see as many of you as possible up there. It will be at the Sky Bar. For those who haven't checked it out yet, it's the top of this building part of the hotel. And we're going to be starting at 6 o'clock. So we will have just some very light nibbles and a bar there to have lots of drinks for those who'd like to stay around. If you do have other plans, please feel free just to pop in, join for one drink. If you want to stay late, we are able to stay up there with our music till 9:30. So you're welcome to stay on after 9:30, but we can't play our own music after 9:30. So I can't guarantee what's going to happen after that. Lanyards. If you are right to, if you still have them, there's always people that lose them, but if you are right to bring your lanyard with you on the Friday night, tomorrow night, it just means that we can just get you through there a lot quicker. If you've lost your lanyard, don't stress, we'll just tick your name off on a list, but hopefully most people have it, so we can just usher everyone through because there is only 2 lifts going up to the top there. As always, feel free to ask myself, Dylan, Max, Delphine, if you do have any questions though, we're very happy to assist. 4 presentations today, same as yesterday. We'll have a break after the second presentation. They all look great though, so definitely stick around, grab your teas, coffees. If you do need to move around, plenty of space at the back. And let's hear it for our first presenter, Indy, who's going to be coming up now. So thanks, Indy.
Hello. Thanks, everyone. Really big thanks again to Quentin and Dylan for inviting me back. Always an honor to be invited, but especially with the Aussie crew. So interesting ECG cases. There's a bunch of different ones I have. So this one, we're going to talk about the ACS manifesto. And last time when I presented in Japan, I didn't do one of these slides, so I had a little slap on the wrist. So who am I? Basically, I'm an emerge doc. I still love emergency medicine after more than 2 decades in it. I do have a bunch of other stuff. And I've done leadership, but everything I've done has basically been because giants have allowed me to stand on their shoulders. So one of the things I keep coming back to and I love is to be able to teach and give something back. So again, thank you for inviting me, and hopefully you learned something today. If not, it's Quentin's fault. Here are my disclosures. Unfortunately, when you have technology that's more than 5 decades old, you can't really get a lot of sponsorships, and none of my ECG talks are sponsored, unfortunately, so that's the bad news. The good news is Quentin did give me 34.87931 minutes for this presentation, so it's always a silver lining. All right, this is another reason why I like these talks. When I go to a lot of the formal kind of conferences to give talks, we have this format we have to kind of go through, including disclosures and objectives. I'm going to leave it blank with your permission, and we're going to come back to it, and then you're going to tell me if you met the objectives or not. All right? Because if I give it away, then it kind of gives away the fun of the cases. And here's the context, right? So we all go to these lovely conferences in Japan, Vietnam, and we enjoy the conference. We learn a few things, and then we come back to practice, and it's a busy day, and you kind of remember something about not using decimals. You remember Scarlett and the Da Nang ambulance drivers, but you don't really incorporate stuff into your practice. So one of the things I really try and focus on my talks is to give you at least 1 or 2 pearls that hopefully you will think about and use and embed into your practice, okay? So let's start off right away. First day back from Vietnam, you're glowing, 59-year-old male with crushing retrosternal chest pain, radiating to both shoulders. Diaphoretic, nauseous, no previous history, huge smoking history, family history. Those are the vitals. What's the first thing you want? Do you want a point or care trope? Do you want a chest x-ray? ECG. You want an ECG, yes. So that's the ECG. Now, hopefully most of you are seeing what I want you to see. And what you're seeing is basically these big blips, right? So we call those hyperacute T waves. If you're a medical student and you see hyperacute T waves, you may have a lot of big differentials, right? Lots of causes for hyperacute T waves. But we treat the patient, we don't treat the ECG. This patient is presenting with crushing retrosternal chest pain, big risk factors, and he has those hyperacute T waves. Now on the back end, we can tell the nurses, let's get ready for reperfusion. But if you have a medical student, you humor them because you want them to understand that the ECG is a snapshot. But your patient is in a disease process that's going to be in a movie, right? So this is a big steak and potato slide that we tend to kind of forget, but the evolution or progression of STEMI or OMI, occlusion MI, is important. So I know you're going to take a photo. If this is the one to take a photo of, just remember what happens, right? So you have hyperacute T waves developing, then you have your ST elevation, and then your Q waves develop as the infarction kind of progresses. As you start having recovery, your T wave, you have T wave inversion, but your Q waves persist, and then full recovery, your T wave is back, but you have Q waves, right? So when you see an ECG like this, typically your ECG might say old infarct, age indeterminate, right? Now, what if the ST does not come down? So you have T wave inversion, but you have persistent ST elevation. Patient doesn't have chest pain, but it had previous MI. So that's a transmural infarct, huge transmural infarct with a ventricular aneurysm, right? So you can have those, but this is an old MI. So treat the patient, not the ECG. All right. So that same patient, if you're not sure, am I going to thrombolize or not? If you don't have access to PCI, if you have access to PCI, primary PCI, most cardiologists will probably take that right away for reperfusion therapy. But if you don't, one thing you can do is just do a serial, right? And as you do a serial one, as you see this patient is evolving, the disease is evolving, the hyperacute T waves will have ST elevation MI. So what does it all mean? So I've used old nomenclature here. I still like STEMI, but I know we have to use OMI. I've used old nomenclature for the older evidence, kind of dating myself here. But almost a half acute MIs will manifest diagnostic ST elevation. What does that mean? That means the other half will not have diagnostic ST elevation. What is our value as emergency clinicians to our patients and to our consultants? Our value is to think about that other half and to make sure we rule that out. That's what we bring to the table. That means a significant number of subtle ST elevation may not be present, so we have to find that. In 2006, there was a retrospective study done. Frequency of failure by 80 provider to detect high-risk ECG findings, 12%. So more than 1 out of 10 patients we were missing, high-risk ECG findings, right? Well, what does that mean? I'm sure we treated them all fine. That then correlated in the same study that high-risk findings, failure to identify them, had a higher odds of not receiving treatment. Okay, we didn't treat them properly, but I'm sure outcomes were same. High-risk ECG findings then associated with a 3% drop. So 8% versus 5% among those with missed findings in terms of mortality, in-hospital mortality. So this is what we bring to the table. We got to find these people, the high-risk ECG findings. Newer literature, new nomenclature. So now we call them OMI or occlusion MI. Instead of the STEMI and non-STEMI paradigm. I'm not going to go over the HAT-W score, but you can look it up if you want. But basically, it said the study that found patients with a positive HAT-W score had an 84% likelihood of culprit lesion causing an acute MI. So failure to recognize these early findings. So if we fail, it actually leads to bad outcome for our patients. So don't rely on the cardiologist and the internist to necessarily find it. It's up to us to find it. All right, so let's move on. That was a very basic case. Here we go. 68-year-old French-Canadian woman traveling from Quebec, very sweet lady, complaining of left and right shoulder pain over the last 2 hours. Radius down the left arm, up to the neck and jaw, nauseated, diaphoretic, no coronary disease, smoked for 35 years, but I only smoke miles, doctor, only miles. No diabetes, no high blood pressure, no high cholesterol. That's the ECG. So I think there's something very not subtle in this, and I hope you see it all. All right, you see the ST depression, right? So this is ST depression. She has chest pain. She probably has non-STEMI. Maybe wait for the trope. We start anticoagulation. Are we good with that? No. I'm seeing some nods. Good. So remember ECG. So I said ECG is a snapshot, right? And this is the disease is happening in real time. So as we can move in time, which we did with the last one, we can also move in space. So you can change your ECG lead placements. If you are suspecting, if you see this, hopefully you're suspecting something, right? Like a posterior MI, because it's anterior ST depression. You could do a 15-lead ECG, which would have V8, V9. And in this one, unfortunately, we did not do it, but the cardiologist was very friendly, so did take this patient for reperfusion. So anytime there's posterior wall MI, right? So AHA, American Heart Association, and American College of Cardiology has basically said these patients are reperfusion candidates when you have maximal ST depression in your anterior leads because it's posterior MI, okay? So that's the ECG again. New nomenclature for updated literature review, basically, 2024 study, again by ASAP saying that posterior leads are often underutilized, so V7 to V9, you don't use it enough. But more importantly, when you have maximal ST depression, V1 to V4, 97% specific for posterior OMI and should be treated as a STEMI equivalent, right? And so what I'm trying to get to you guys is when you see ST depression in the setting of what sounds like ischemic chest pain, think about, I know we're trained to think ST elevation, but when you see maximal or major ST depression, think, is this an ST elevation? Is this just reciprocal changes somewhere else that I'm not missing? And if you think about it, again, that's the value we bring as emergent doctors. If you think about it, you'll probably land on something. And sometimes it may be just non-STEMI, and that's okay, but we've done our job. All right, next case. 47-year-old South Asian male, red flags going off, complaining of 90 minutes of indigestion, heartburn, associated with nausea, no past coronary artery disease history. He is diabetic, he is hypertensive, shocking, and history of GERD. All right? What do we want first? We want to give him Pink Lady and send him on his way, right? All right. We got a good crowd here. All right. So that's the ECG. Again, you don't necessarily need to look for the subtle changes. Shout it out. What are you guys seeing? There's something that's not very subtle in this. Anything? Anybody? Okay, inferior leads. Look at your inferior leads, 2-3 AVF. All anatomically contiguous leads, 2-3 AVF, all your inferior leads. Are we seeing ST depression? Right? Your TP is your isoelectric point, so you always compare to that. And you are seeing ST depression in inferior. And what did we say? When you see major ST depression in anatomically contiguous leads, think about an ST elevation in a reciprocal, right? Very subtle, but there is ST elevation in AVL. So this is not actually a non-STEMI. This is not to be treated with anticoagulants and sent home. This is a patient who needs reperfusion therapy. Yeah? So, learning points on this. Lateral wall, very silent, unfortunately, because of the way we do it. Now, you could put a V7. You could move your leads, V7, and catch it if you really want to. Understand that the size of the risk, myocardial risk area is quite high, but in a traditional 12-lead ECG, electrically silent area. Yeah? So if you see ST depression in contiguous leads, think about, is there ST elevation somewhere that I'm missing? Okay, so marked ST depression in inferior leads means there may be an occlusion MI happening in your lateral wall. Think about it. Could be RV, could be posterior wall, till proven otherwise. So as an emerge doc, I need to really prove to myself this is not an ST elevation before I just start anticoagulation and send the patient to the floor.
Would V4 right have any type of indication on that? So if you did the right-sided
V4, so RV, yeah, I mean, to me, look, I think there's no harm in getting more information. So if you want to V4R, just do it. It doesn't take that long. It's non-invasive. If you think I'm going to get more information, do a V4R. You can even do V5, V6R. You can put the leads anywhere you want because you know what area you want to catch, right? But you're seeing major ST depression in your inferior leads, be the hunter and look for the ST elevation, yeah? So borderline ST elevation may represent STEMI, be missed. You have to initiate serial ECG, so space and time, right? So you can do, if you're not happy with one, do another one 10 minutes later, see if it's changing. Is there a dynamic ST depression happening? Does dynamic ST depression happening think that my lesion in that coronary artery is dynamic? And this go to occlusion. Is this an actual occlusion, am I? So circumflex first diagonal artery, again, don't have to remember the anatomy necessarily, but if you have minimal ST elevation in AVL, because the R wave amplitude is low. So your first clue, and maybe your only clue, might be the significant inferior ST depression, all right? So again, on the more newer stuff that you read, the new literature, and I always try to do a lit review update on all the talks. This has become kind of a popular thing, this whole South African flag sign. But the main message I want you to take away is that lateral wall occlusions, elevation AVL is minimal because the R wave amplitude is low. So making inferior ST depression the primary clue for the clinician. What is a South African flag sign? So what you basically look for is ST elevation in lead 1, ST depression in lead 3, and then ST elevation in V2 and V7. So kind of your lateral leads, if you think about it, these are your lateral leads, V5 and V6. Now, did our patient have that? Our patient didn't have that, right? Our patient did have ST depression, did not have ST elevation here, did not, and maybe had some ST elevation here, but no ST elevation here. Will that stop us from doing what we need to do? No, because we're trying to treat the patient. So it doesn't have the classic South Africa flag sign, but we know that they have significant ST depression in your inferior leads, and they're having crushing retrosternal chest pain. You're starting to think about MI. You look at it a little bit more closely and like, I think this might be. I might be able to turn on the amplitude. I might want to do a V4R, 15 lead, look at the lateral wall more, may do a more precordial, so move the V6 to V7, V8 and see if you can catch that wall. And you're going to talk to your cardiologist and say, I'm really worried more about an OMI in this patient. All right. 55-year-old male, presents with 2-hour history of left-sided chest pain, diaphoretic at rest when the EMS picked him up. Now the pain is completely resolved. So the pain is completely resolved. Our triage nurse has put the patient on the side. The paramedic comes to you and says, hey, doc, I'm a little worried about this. Can you take a look at this ECG? He's chest pain-free now. Now, this one is a little subtle, but I think we'll agree it's not a normal ECG, yeah? Maybe normal, maybe not. But I do want you to see these little, what we call biphasic T waves, yeah? You guys seeing that? The key, though, is this patient had chest pain and is now chest pain-free. So they're sitting in triage because we have people with active chest pain, people with active strokes coming in. Go to see this patient. Exam regime is normal. I've already shown you the ECG. Tropes are normal, ×2. Repeat ECG, no change. Send patient home. What are we going to do with this patient? Refer the patient. Admit it to medicine. What does medicine want to do? Even though I told the senior medical resident that day, I'm not going to say the name yet. I don't think this patient should be sent for a stress test. And we talked about communication on day 1, I believe. The handover didn't get done. So this patient was sent for exercise stress test the next morning. This patient died. Despite thrombolysis, big M&M rounds, big investigation done. 80% left main occlusion, 95% occlusion of the proximal LAD. These proximal lesions are deadly, And there's very subtle findings, right? And it's up to us. Again, we have to catch them. Yeah? So it's called Wellens. I'm sure some of you have heard of it. If not all of you have heard of it. And there's some key things about this, right? There's a prior history of chest pain. So at the time you're seeing them, they may not have chest pain. And so often we can tend to get a little more relaxed, which is okay. The patient not having acute symptoms, I don't need to send the patient to cath lab right away. The other thing is there's really little or no cardiac enzyme elevation. There's no precordial Q waves. There's little or no ST segment elevation. So there's really not a lot of clues. But if the patient has risk factors, he had chest pain that sounded very ischemic, now chest pain free, and you are seeing biphasic T waves in your precordial leads, again, anatomically contiguous leads, you have to think about a big, tight proximal lesion, right? And there are case reports now. Now, this is the classic Wellens syndrome is V1 to V3 in LAD, but there are case reports now for RCAs and stuff, so having the same biphasic T waves in contiguous leads that basically show a proximal lesion in that culprit. So RCAs for inferior Wellens syndrome. So let's look at that again. We have a patient now who had chest pain, is now chest pain free, has biphasic T waves, right? Indicating to you that this patient may have a very tight proximal LAD lesion. And if that thrombolizes, this patient might die, right? Ruptures. So we don't want that plaque rupture, yeah? That's Wellens syndrome type A. This is Wellens syndrome type B. Remember again, the disease is something that is progressing. Most of us will probably not miss this, it's not as subtle, but you have to think about what it is, yeah? So if you take the same Wellens A patient and you continue doing serial ECGs, eventually it will evolve to that. So sometimes you may see the patient presenting with that because the Wellens A is already passed. So if you see, again, a patient who had ischemic sounding chest pain is now chest pain free and anatomically contiguously is having deep inverted T waves, please think about Wellens. Please tell your internist this patient should not have stress test, should go straight to angio, yeah? So what's the pathophysiology? The theory is that it's probable transient STEMI due to occlusion of LAD that, before the ECG recording, reperfused spontaneously. All right, so your T wave inversion in your precordial leads, also the high incidence of critical narrowing of proximal LAD, high risk for reocclusion with recurrent STEMI. So that's really what you're trying to prevent in these guys. What does the new literature evidence say? Wellens type A and type B specificity of 99% and 97% respectively for LAD occlusion. High specificity. Numbers really hard to argue with. This is really our message to our internists, right? All of the literature strongly reemphasizes stress testing is contraindicated. Exercise or nuclear stress tests, you don't want to stress these patients because you don't want that big, tight lesion to rupture. Okay? All right. How are we doing on time? 34.72 minutes, we good? Yeah. 83-year-old man presents with 1 hour history of chest pain radiating to left arm. It's 1 a.m. Sunday morning. Has all the risk factors that you can think of. And I'm sorry this doesn't project really well, but hopefully enough for you to see the not very subtle findings. Are we seeing not very subtle findings? Yeah? Are they in anatomically contiguous leads? Right? Anterior, inferior, lateral. Yeah? Are we seeing lateral lead? Significant ST depression. What did we say when we see significant ST depression in anatomically contiguous leads? So in this one, the resident was good. I did a 15 lead, right? So saw significant ST depression in the lateral leads, did a 15 lead. We have V4R elevation indicating RV infarction. So OMI in your right ventricle. Why is that important? Why is RV? I mean, they're obviously going to go for reperfusion. But what are you not going to give them? Sorry? Yes, you're not going to give them nitro, right? These patients are very preload dependent. You give them nitro, you're going to go, patients are going to go into cardiogenic shock right away. All right? So again, significant ST depression in contiguous leads, I have to think about ST elevation. That's my role. That's my value. Now, you may go through it and say, no, it's not ST elevation. But if you don't go through that process and that thought, you're going to miss patients. So when marked ST depression is seen in the setting of ischemic chest pain, we are the hunters for ST elevation and reciprocal leads, and utilize serial and 15-lead ECG whenever you can. Easy, non-invasive, quick. Next one, 42-year-old male, previously well. And the nurse comes to you. They all know this guy. Handsome, strapping firefighter, comes in all the time, helps patients out, never complains about anything. He's a smoker. 1 hour steady pressure in his chest, onset while watching a movie at around noon on one of his days off. Otherwise, pretty unremarkable. He is well loved, so his door to EKG time was really fantastic. And that's his EKG. Now, I think most of you will see, right? There is, again, anatomically contiguous. I don't think you'll miss it, the ST elevation. But when I go to see this patient, he's reading a newspaper, he's having a coffee. He's like, hey, doc, how's it going? Yeah, how's it going? You still having some? She's like, yeah, it's a little, it's grumbling a little bit in here, but, I think I'm okay. But, the missus said I should come in and get it checked out, so here I am. This is 1 a.m., and I will tell you this was my first month of practice. So I'm sitting there thinking, what do I need to do this guy? Like, I think this is a ST elevation, am I? But this guy's sitting there, reading the newspaper. He's not diaphoretic. He seems pretty calm, pretty comfortable. And I'm glad we had the talk on the second day about pain. The patient had chest pain. Now, if I was this guy, maybe I'd be sweating, maybe I'd throwing up a storm, maybe having all kinds of dramatic kind of episode. But this guy is stoic. He's sitting there. But he has chest pain, and he has ST elevation. I still picked up the phone. I spoke to the cardiologist. And he's like, well, what do you think? Do you think this guy's infarcting? I said, I don't know. He's sitting there reading a newspaper, having a coffee. I don't know if he's having it. So we did all the tests that we needed to do. Serial ECG is done. There's no really dynamic change in his ST elevation. Did some 15 leads, no abnormalities. Chest pressure is continuing, but patient is in no apparent distress. Did bilateral BPs. Am I missing dissection or something like that? Chest X-ray is normal. We decided to give him thrombolysis. So shared decision making. I went and I spoke to the firefighter. I said, listen, I think you're infarcting. I'm not 100% sure. We don't have access to cath lab. If you were my relative, I would say you take the TPA. You have very low risk of interstitial hemorrhage. 30 minutes post-TNK, the nurses call me stat for this rhythm. Are we worried? I see you're not there, not worried. Okay, tell me why. This is very classic reperfusion rhythm, accelerated idioventricular rhythm, okay? So when you actually give a patient thrombolysis, anywhere from 30 to 90 minutes post, this rhythm is very common. You do nothing. You say nothing. You just stand bedside. You hold the patient's hand. You say, how you doing? They probably won't know what's going on except for the alarm bells going off. And
Don't let them look at the corner.
exactly. And you tell the nurses it's okay. And repeat ECG, done about an hour later, is that, right? So this is an aborted MI, yeah? We got it in time. Now, there's still going to be some damage, obviously, to his myocardium. He still needs the whole workup, et cetera. But this was an aborted MI, where we did the right thing. But in the context of communication with the cardiologist, with shared decision-making with the patient, not a classic presentation, unless you're just doing a textbook definition, right? The patient had chest pain, he had ST elevation, I'm going to treat. But not the classic ST elevation presentation. All right, so what's the summary? ACS is very well recognized, but it's very critical to differentiate non-ST elevation ACS from ST elevation because the treatment is very different. One set of patients are going to go for reperfusion therapy. The other is going to get treated medically with anticoagulation. Use your serial and your 15-lead ECGs and or other leads to help you. Be on the lookout for subtle ECG findings, right? So hyperacute T-waves, posterior STEMI, marked ST depression, that's the big one. Think about Welland syndrome when you see the biphasics in someone who's chest pain-free. And now you're experts, so now here's the case. Here's the bonus for some extra points. This, again, was probably my second month of practice. Handover from a guy who has won every award that we can think of. He was a senior medical resident at the time. He has won even now as a staff. This guy is brilliant, okay? But this goes to show you how night shifts can really play with our minds. So he's coming off nights. This is one of the handovers. 49-year-old female came in with chest pain, agitation, tachycardia, known cocaine user, known to us quite well, actually. Admitted to cocaine use for us prior to presenting to emerge. Those are the vitals. Oops. Vital signs. First trope negative, plan, second troponin negative, discharge home. So fresh set of eye is always a little different, yeah? So that's the ECG I see. Anyone seeing anything? So it doesn't project well, but. The one thing I think we'll all agree, the patient has sinus tachycardia, right? So sinus tachycardia, but she used cocaine. This is 6 hours post-cocaine, still quite tachycardic. Benzos on board. Second troponin and home, right? I go to speak to the patient because we treat the patient. As usual, she's not very cooperative, but she's able to tell you her chest pain is sharp, and it's worse when she takes in a deep breath. She does complain of shortness of breath if you ask her. Yeah, I'm short of breath. No injury, no trauma, no history of asthma, lung disease, no recent infectious process. Let's go back and look at the ECG again. ST elevation, pleuritic chest pain. ST elevation. Chest pain, pleuritic chest pain, and sinus tachycardia. You should be thinking about something, yeah? So we're not going to get sidetracked by the second troponin and home because of cocaine use. We're not talking about the red herring. And if you see clearly, and the only reason I put this on is in my 20-some years, this is the only 2 cases I've had of this. If you look a little more, you look S1, Q3, T3, yeah? It's, again, classic textbook, just like the South African sign. You don't see it very often. When you see that sinus tachycardia and pleuritic chest pain, think of PE, obviously, yeah? So I know this is an ACS talk with ECGs, but this goes to show you the ECG is so helpful for many other things, and it's easy to kind of get waylaid because you're thinking, right? And we talked about biases. That was an anchoring bias, and we would have continued that anchoring bias if we don't look at it with a fresh set of eyes. So again, in terms of the new literature evidence, S1, Q3, T3 pattern inversion independently associated with intermediate, high, and high-risk PE. All right? So if you see S1, Q3, T3, that's definitely high. And critical early warning sign of saddle PE, which are, as we know, are pretty dangerous pulmonary emboli. All right. So here were the objectives. Did we meet them? You can tell me. Case-based discussion of ECGs in the context of patients presenting with chest pain. I hope you will appreciate now the importance of hunting for ST elevation and learn clues on hidden ST elevation, right? A lot of these is hiding. And you're going to think back about patients that you saw ST depression, and you said, it's non-ST elevation, treated with 2 double antiplatelet anticoagulation and admitted them to medicine. Understand how and when to use serial ECGs. You change your lead positions when you can. Use it as a tool in your armamentarium because you have it, you know how to read it. Think of anatomically contiguous lead. If you have any further questions, I may not answer right away because I will be having a beer tonight. I'm happy, but I will answer. Thank you.
This is a presentation that's been 6 years in the making. So Chris and Roz were scheduled to talk for us at our Bali conference that was going to be in May 2020. Unfortunately, a few things happened that made travel not possible for that year, but finally we've got them back. We're really excited. They've got Alex along with them as well. So yeah, get ready, strap yourselves in for a 6 year in the making presentation. Let's hear it for Roz, Chris and Alex.
Gosh, what an introduction, thank you. Kia ora, tēnā koutou katoa. Hello and greetings to you all. My name's Chrissie and these are my two colleagues, Roz and Alex. Thank you for allowing us this opportunity to talk to you today. We are nurses based in the South Island of New Zealand, where we work at Wanaka Medical Centre as practice nurses.
Despite difference in scale, New Zealand and Australia face remarkably similar pressures in rural emergency care. Distance, workforce constraints, increasing demand, response time pressures, and sustainability. We are 3.5 hours away by road from a tertiary hospital. We are a very busy general practice with 8 practice nurses, 10 GPs, and 3 nurse practitioners. We have 1 crewed ambulance per shift with a paramedic on board, and in the winter we have another crewed ambulance which joins us. Often these ambulances are not available as they could be out of town transferring patients to hospitals or attending other incidents.
Whether it's the Australian outback or rural New Zealand, distance remains one of the most unforgiving clinical variables. We can optimise systems, but we cannot optimise geography. We have a wide land space, and many live or spend time in isolated locations. Many live out on secluded farms or spend time hunting and fishing in hard-to-reach places, locations where terrain can be dangerous, weather can be variable, and activities can go wrong.
Recruiting staff in Wanaka is sometimes difficult. Although it's an amazing place to live and work, living there is expensive. As Roz mentioned earlier, we only have 8 nurses, but fortunately we have good staff retention. In addition to our local ambulance service, which is St John, this is also stretched and they rely heavily on volunteers. Hence, fatigue and burnout are common. On any given day, Roz, Alex and myself manage acute medical emergencies in adults and children, provide sexual health and mental health care, administer vaccinations, give travel advice, conduct skin cancer surveillance, manage long-term conditions and undertake occupational health monitoring. But our most demanding and high-risk role is that of being prime responders.
Demand isn't just increasing, it's becoming clinically heavier. Prime call-outs are diverse and often confronting. They include ski accidents on icy terrain, boating incidents on remote lakes, motor vehicle crashes on winding alpine roads, and medical collapses in isolated homes. Often rescues require helicopters and boats.
In rural medicine, response time is not just a metric, it's physiology. Every minute counts, putting a lot of pressure on our already strained ambulance service. When seconds stretch to minutes, even hours due to geographical isolation, the delay can directly translate to poorer outcomes. These pressures raise a difficult question. If distance cannot be removed, if workforce shortages persist, how can we improve early emergency care? A rural GP named Dr. Trevor Walker, based in Te Anau in the South Island in the 1990s, recognised that this needed urgent attention. Could the person who had a heart attack in the remote farm cottage have been better serviced? Could the severely injured car crash victim fared better? Could the farmer, when his tractor rolled, have had a better outcome? The underlying question for Dr. Walker asked was, could first responders be better trained, supported and equipped to work together to provide acute accident and emergency care in the time-critical situations, often in very challenging environments outside a general practice or hospital? The Southern Regional Health Authority was similarly concerned and employed him to investigate the matter. He toured the length of the South Island, meeting as many first responders as possible. Dr. Walker noted emergency services often used different protocols and guidelines. Services and coordination was at times poor. Fire, police and ambulance personnel reported to different control centres. Patients were not always directed to the most appropriate hospital. After much hard work, he designed and set up the now highly regarded pre-hospital care system called Primary Response in Medical Emergencies.
The Prime service got underway in the South Island of New Zealand in 1998, followed closely by the North Island 2 years later. It enables trained rural nurses and GPs to respond to 111 emergency calls in their own communities.
Wanaka is a small town in central Otago in the South Island of New Zealand. It has a steadily growing residential population alongside increasing numbers of holidaymakers and tourists who visit each year. Wanaka has roughly 16,000 to 18,000 permanent residents, and they estimate 3 million visitors a year. Wanaka is a town of high-risk outdoor sports and seasonal influx, and there are 3 general practices but no hospital. As Ros previously said, the nearest hospital is in Dunedin, which is 3 hours drive away. There are many young families in Wanaka who have come to optimise the outdoors, but there's also a lot of ageing population. Many move there to retire.
Wanaka is rural but not quiet. Tourism, populations growth, seasonal surges, outdoor activities are all steadily increasing. Wanaka has experienced rapid growth over the last decade, transforming from a holiday town into a booming residential hub. The population growth in Wanaka and surrounds has averaged 4% per annum over the last 5 years. And as Alex mentioned, it's between 16 and 18,000, with over 3 million tourists visiting annually. We have 4 very distinct seasons featuring a continental climate with cold, snowy winters and warm, dry summers. We are surrounded by snow-capped mountains, pristine rivers and lakes, including Lake Wanaka, New Zealand's 4th largest lake. We have 2 major ski fields, Treble Cone and Cardrona Alpine Resort, which is the largest ski resort in the Southern Hemisphere. Just beyond our town lies Mount Aspiring National Park, an area known for its dramatic alpine wilderness, vast glaciers, deep valleys and fast-flowing rivers. During our winter months, much of our work involves ski-related trauma, fractures, spinal injuries, hypothermia and head injuries. And in the summer, we see a high volume of mountain bike crashes, boating injuries, hiking injuries and environmental emergencies such as exposure and dehydration.
We cover a 70-kilometre radius which stretches from the Cardrona Valley to the Lindis Pass and Haast Pass. To our Australian counterparts, it might not sound huge, but due to our mountainous terrain and ever-changing weather conditions, this can be challenging. Rural GPs and nurses, we know our community. We know the geography and its limitations. We know which roads flood, which mountain passes close in snow, where comms are limited, and where helicopters can and cannot land. We also take our own cars to prime call-outs, so we know who's got the best four-wheel drive, who's likely to have chains, and who's likely to have gas in their car.
In our region, prime responders are rural clinicians. We are all trained prime responders, all with a variety of clinical backgrounds and experience. The initial prime training is an intense course run very efficiently by St John's, with 2 yearly refresher courses required.
Following the 111 call, the St John dispatch team then put out the pager alerts. We then phone dispatch to gain further information, which is often not too much, where it is and what it could be. Generally, 2 staff members from Wanaka Medical attend, however, at times it is necessary to send more, and this does place strain on the running of the day-to-day medical centre. We cover prime from 8:30 in the morning till 6 at night, and then it's covered by nurse practitioners from 6 till 11. Overnight, there is no prime cover, which is something that's currently being reviewed.
Prime has been shown to reduce time to clinical intervention. It is improving trauma outcomes and it has increased cardiac arrest survival rate. Prime is based on the principle of equity. It recognises that where you live should not determine whether you survive in an emergency. Just as importantly, it gives rural communities confidence that help is close. Prime is not an ambulance service and it is not a hospital. It is a bridge to get advanced clinical care to patients much faster.
Situations are generally time critical and resources are limited. Prime response allows for early intervention, advanced care and structured medical attention. Both the ambulance crew and the medical centre carry the full prime kit to situations. All kits are strictly packed the same and include a range of necessary equipment and resources to cover a wide range of medical and emergency situations.
The prime role aims to provide early assessment, stabilisation and decision-making support. This service has created a really nice collaboration between rural GP practices and St John, and it reinforces that we're all one team. By working together as one team, it helps to support better health outcomes for the individuals.
Distance will always exist in rural medicine. Geography cannot be eliminated. The delivery of advanced clinical care is something we can change. Prime is the way in which New Zealand has chosen to address this challenge. It is a major success which has survived multiple governments. No exact figures for the number of lives saved has been published, but the prime training for rural healthcare providers has saved and it will continue to save the lives of many across Aotearoa.
So we want to thank you all very much for allowing us to share our story. It's been a privilege to share our experience of a service that plays a critical role in saving lives in some of the most isolated and challenging environments in New Zealand. It is important and significant work that we do, and we are very proud to do it. Tēnā koutou, tēnā koutou, tēnā koutou katoa. Thank you, thank you, thank you all. Just wanted to ask if anyone has any questions. Thank you. Or suggestions?
Yeah, so I noticed you're talking about St John's were voluntary drivers?
Yes, voluntary workers as well. We always have one paramedic on an ambulance. We only have one crew per day, one crew per night, and the second crew member is a volunteer, unpaid volunteer. Yeah.
So the question was,
They do. They have basic life support. They start off primarily as an observer, and then they do some courses on basic life support and first aid. So their role is limited, and it does make it quite difficult for the paramedic. So that is where Prime steps in, really. So we support the ambulance service.
I work as a rural remote nurse in Northern Territory.
Yes,
And I'm the ambulance driver.
you're it.
I'm there.
Yeah, yeah,
And we would have a driver with us.
sure.
But yeah, none
Yeah,
of them have basic life support.
right. Yeah, no.
I'd like to encourage them, we need all our drivers trained in basic life support.
Oh, absolutely.
A little bit more helpful to the nurses.
Yeah, for sure, for sure. Do you have you don't have a GP or any other nurses around? No, no.
2.5 hours
From,
closest hospital.
yeah, for sure.
We were locked out access to anything for 6 weeks because we were flooded in.
Oh, wow. Yeah, that's tough. Absolutely. Yeah, yeah. Hello.
Is the practice privately owned or is it all government?
It's privately owned. Yep, we've got
So how do you get refunded for the time?
ACC, which is a government we do get government funding for accidents. So anyone visiting New Zealand, regardless of where you are from, if there is an accident in New Zealand, or you have an accident in New Zealand, you get free health care. Yeah, reciprocal with Australia. And Prime, we do get paid by the government, but the practices are all private. So we get paid for ACC call-outs and Prime call-outs, yes. Or reimbursed, yeah. Hello.
Can I just seek a bit of clarity around
Of course.
the terminology? Everyone from Australia is looking at that logo, St John, and sees it as a volunteer organisation.
Sure. No,
Most states, but I understand in New Zealand that this is your paid.
this is our paid ambulance service. Yes, absolutely. It's all we've got in the South Island. Wellington, which is in the North Island, they have Wellington Free Ambulance, which is a paid service. And I think up north they have another ambulance service, but all of the South Island is St John and it is paid, but volunteers do help. Yeah. Hi.
I know you said you've got good workforce retention,
Yes.
but just wanting to know if you have any succession planning.
Sorry?
Succession planning. Do you do anything to attract people?
Yeah, we take new graduates. Well, it's a very good question as far as I don't know what we really do to actually encourage. Can you girls think of anything? Yeah, we do. Us, fortunately, our managers, they look after us, hence why we're here today.
People want to live in Wanaka.
Yeah.
Yes, yeah. That, as Alex says, Wanaka is a beautiful place, as you can see from the slides. But it is an expensive place, and we're fortunate with staff retention, but we do lose a lot of our younger nurses to Australia because the money's better, and it's a no-brainer for some, Yeah. But, we've been there a while. We getting a bit longer in the tooth, and we enjoy what we do. So, we're staying put.
All right, let's hear it one more time. Thank you. I think it's always great to have insights of what's happening elsewhere, especially coming from WA. I can certainly see similar towns like your Margaret Rivers and stuff, which we also have the boom of tourism. So don't be afraid to go back to your organisations, be the voice of change, or go move to Wanaka because it looks pretty good. So definitely I reckon New Zealand tourism should be paying you guys for some of the photos up there. Let's take a quick break. 15 minutes. Then we'll be back in this room and Rob's going to be kicking things off for us. So fill up your tea, coffee, bellies, and we'll see you here soon. It's time for our photo competition. 4 t-shirts to give away today and a bunch of passport wallets. So you guys should know the rules by now. Loudest cheer gets the prize. If you haven't put your photos up on social media and tagged us, still time. Tomorrow, prize bonanza tomorrow? Yeah, prize bonanza tomorrow. So keep the photos coming. All right. We've got some really good photographers in the room. So just as a heads up, there's some pretty amazing photos. So feel free to do a polite clap for all of them. But big cheers for the ones that really resonate with you. So let's get going. Number 1. That's a pretty good little, yeah. It's not a bad way to spend the day. Oh. Some good ones to warm up. Bit of banh mi. I think so far we've got a winner, but there's some good ones coming. The lanterns. Mine's just a blur when I try and do those photos. That's awesome. Oh, Bob Marley bar. I'm surprised the Mr. Bean bar hasn't featured yet. We had someone threaten to do the Mr. Bean dance in front of it for a t-shirt, so we're still waiting to see that one come through. Oh, that's nice. I think so far we've got the banh mi getting a t-shirt. Ah, cocktails. Ah. Yeah, look at that. The colours, everything about that photo, it's impressive. And this is the whole group doing the Vespa tour. All right, so far we've got banh mi, we've got the scooter, we've got the Vespa gang. Last photo, will it get a prize? Yeah. Don't know if you can see, but actually levitating there, so don't think we can't give a prize to Jesus. So it's impressive. So there are our 4 winners. Everyone else who submitted a prize, please come see Dylan, get a passport wallet at the end. Big round of applause to everyone who submitted photos. Thank you though, because it really is something that we love seeing is all those photos from out and about. So I really appreciate everyone submitting those. If we didn't get a chance to show your photo up yet, apologies, it is hard to get everyone's there. As you know, I like to keep to time. So tomorrow though, we'll try and include a whole lot more and give away everything else we have left because we don't want to take it back to Perth with us. As Rob comes up to the stage to do his second presentation for the week, just a quick reminder that we do have some workshops still on this week. So we've got our ECG rhythm recognition one this afternoon. Then we're looking at a bit of chest trauma and TBI tomorrow afternoon. 2 or 3 spots left for this Arvo, and I think 3-ish, 4-ish spots for tomorrow. Can you still take more tomorrow, Rob? We can still take 5 tomorrow. So if you are feeling like a little bit more PD is what you're after this week, certainly check out those workshops. Otherwise, sit back, relax, and enjoy Rob's presentation today. Come on down, Rob.
Hey, good morning, everyone. It always surprises me what I'm going to talk about. I give these guys all my lectures and they just throw something random up and say, can you do a fill-in? So here we are. Let's talk about rhabdomyolysis, something I think I experienced yesterday. My darling bride decided, hey, let's see a little bit of Vietnam. So took the fat man on a 2-hour hike up a mountain to see some old ruins. It really was amazing. But I can recommend taking the helicopter and just landing at the site. I have never felt so achy and seen urine that looks more like Coca-Cola than this morning. So if this is not living your art, I don't know what is. For those that don't know me or weren't here yesterday, Rob Timmings is my name. I'm a nurse from Brisbane. And I do this. I teach usually small groups up to around about 20, 25, 30 people in small workshops. I am running a couple of workshops this afternoon. We're back from 1 o'clock until 4. And then I have to do an online presentation, part of a trauma workshop that I'm teaching into. And that session today is on burns. It'll be free for anyone that just wants to sit in. I've got to do it on Zoom, so I thought I may as well just leave my computer hooked up here and do the lecture to whoever is out there in Zoom land listening. If you wanted to sit in on that, that's a 1 o'clock until, no, a 4 o'clock until 6 p.m. tonight. It's about a 1.5 hour lecture on burns, part of my trauma series. And of course, this really comes straight from that. So what I'm going to talk to you today about is rhabdomyolysis. Of course, we know that we shouldn't have objectives, so I'm getting rid of those. That's my bad. I just fell into teacher mode all of a sudden. Let's talk about what rhabdomyolysis is. Rhabdo means, in Greek, stripe-like, or rod-like too. Smooth muscle, yeah. So the stripy muscle we're talking about, for the most part, is skeletal muscle. When we talk about, have a conversation around rhabdomyolysis, lysis is, of course, to break down. So lysis, if you didn't get the memo right at the very beginning of your medical career, you always read these big, long medical words backwards, right? Lysis, to break down myo muscle, that is stripy, not spicy. A little bit of Vietnam just oozed in there. So what's the problem with having muscle that breaks down? Other than the fact that you have an injury and it repairs, we know that cells repair, we know that tissue repairs. What is the problem with rhabdomyolysis, and why is it something that we're particularly interested in pre-hospital and emergency medicine? And it really has to come down to a very simple analogy, and that is if you squeeze a grape or any other piece of fruit hard enough, the juice is going to come out. And when the juice comes out, no longer is that grape or that piece of fruit viable. Number one, it's damaged. But the juice itself can become harmful. And it's the juice itself that's coming out of muscle when it's become squeezed, when it's become damaged, or when that muscle starts to lyse, starts to break down or die. That's what becomes the life threat in a person who's experiencing rhabdomyolysis. So we talk about, well, what's inside of a muscle that should really stay there locked up inside of a muscle? And it's those large proteins that carry oxygen. Like we have hemoglobin in our red blood cells, myoglobin in our muscle cells are the chief oxygen-carrying pigment or protein that's inside muscle. Now, it's supposed to be in muscle. It's not supposed to be in your blood, and certainly not in your serum, where large molecules of this protein myoglobin can clog up kidneys. Inside muscles, we know that there's a large amount of phosphate and a large amount of potassium. So, of course, those intracellular contents will leak out when a muscle is damaged. So we're going to see a potassium rise in those patients, and we're going to see an increase in phosphate in those patients. And we'll talk about the consequences of those very shortly. Renal toxicity becomes the end game if the patient survives to get renal toxicity. And I guess this is when we talk about the very early deaths from rhabdomyolysis that occur as a result of potassium rising causing cardiac toxicity. Kills you dead before the kidneys get clogged up. Versus if you can keep your patient alive long enough from the cardiac assault of that potassium leak, myoglobin may just take out somebody's kidneys and give them an acute kidney injury that will cause long-term sequelae secondary to having this muscle injury. So we're looking at keeping a person alive very, very early on, but also in that third peak, we want to keep people healthy and maintain renal function. And of course, acute kidney injury is where we are hoping to avoid the fallout from acute kidney injury. So how do we get rhabdomyolysis? How do we get muscle injury? Well, there's 5 main mechanisms. Of course, the first one, and the one that you're mostly thinking of, is a crush-type injury or overworking of muscle. So it can be physical exertion, it can be prolonged seizures, particularly in prolonged status epilepticus. We can see rhabdomyolysis developing, or muscle destruction. Extreme exertion, like that walk that we did yesterday, darling. Heat stroke, like that walk that we did yesterday, darling. Prolonged immobilisation, like that rest that we had when we got home at 6 o'clock after doing a long walk yesterday. Crush injury, entrapment, long lie. We've all seen long lie. Nana who falls over and isn't found until the next morning. And now we get that reperfusion injury and that washing out of all of those intracellular contents. The fruit's been squeezed, the juice has come out, and now that juice is going to enter into our serum as we start to remove that pressure. Medications, absolutely. So 5 main causes. Thank you for segueing me to medications. That's the next slide. Did you get her to speed up the process? You did. What are we seeing here? We're seeing this is the result of a compartment syndrome that somebody's had as a result of an injury to their calf. A very, very dusky, nasty-looking muscle here. Got to give points to the doctor in the ED for slicing this thing open and letting the swelling free. Yep. So I'll give him points for that. He loses points for not figuring out how a bluey is supposed to work. So sometimes you doctors have got it together as far as knowing what to do, but how to do it, you could do with asking a nurse, okay? Just putting it out there in the most positive way. Some doctors will say, well, what's a bluey? All right, of course, we're stitching it all up. Alrighty, so let's have a look at medications. Statins have been associated with it. Certainly some of the psychostimulants, so those rave party drugs, the type drugs. I had to practice that. Antipsychotics, we see it with very, very rarely with antipsychotic use, particularly the older antipsychotics, those big dopamine 2 antagonists that can sometimes induce neuroleptic malignant syndrome, and the same process that we can see with anaesthetic medications that can cause a malignant hypothermic syndrome. Certainly in the street party drug rave scene, we see serotonin syndrome that can result in rhabdomyolysis. So most definitely drugs are a big part of that. Drugs like cocaine, amphetamines, alcohol, particularly toxic alcohols, in places where you might partake of 2-for-1 type cocktails that may not necessarily be from the original bottles. Can I just say, just from a safety point of view, if there is a chance that you think that you may have been intoxicated with methanol or a toxic alcohol, the treatment is alcohol. So always have a bottle of vodka ready to help yourself, just in case Envenomation. We don't see a lot of rhabdomyolysis from envenomation in Australian snakes. Most of our Australian snakes are associated with hemolytic anemias and coagulopathies. However, in places like India and Africa, where we get a lot of the species that have myotoxic venoms, then we tend to have a much, much higher incidence, or we see statistically a higher incidence of rhabdomyolysis through those sort of bites, vipers and cobras and rattlesnakes and those sorts of species that we don't have in our country. By the way, my little logo is moving ever so closer to the middle. When it gets to the middle, we're halfway through. That's just your little indicator of where I'm up to. Question? Yep. Extreme exercise, yes, but not specifically from GLP-1. In my reading, I could stand to be corrected. GLP-1 is not something that I'm living and breathing yet. But so no. I guess one of the bigger issues with GLP-1 is that as people start to lose weight, they start to think, well, now I can probably go and do some CrossFit. I don't get that either, but right, but and then what they're doing is they're taking perhaps years and years of poorly toned muscle and trying to do something rather exceptional with it without working towards that. It's kind of like this idea that you wake up one morning and decide you're going to do a fun run when you haven't done any kind of preparation for again, two words that are never seen in the same sentence: fun and run. Okay. Hypokalemia, we see it in DKA and HHS, which I still to this day think we should still call honk. Yep. Hyper and hypothermias, Joe, and of course infections. We can certainly see it in sepsis. So lots and lots of causes. So irrespective of how I squeeze the fruit and the juice comes out, irrespective of how I got there, the problem is the juice is coming out, yes? So it doesn't matter whether it was a crush injury or whether it was medication-induced or... The etiology itself is of less importance than the rescue. And I think in emergency medicine, sometimes we have to think about the rescue before we can do the investigation, or concomitantly with that. The classic triad. This will be on every single medical and nursing and paramedicine exam. When suspecting rhabdomyolysis, what's the classic rhabdo triad? Is this what you were taught? Muscle pain, weakness, swelling, dark tea-coloured or Coca-Cola coloured urine, and an elevated serum CK. We see it in less than 10% of people with rhabdo. I'm going to say that again. We see it in less than 10%. The three classic symptoms we see in less than 10% of rhabdo. So if we're relying on just those three and ignoring the other symptom sets that we may see, you can see how it can fly under the radar, particularly with medication use. We see the kid coming from the dance floor with serotonin syndrome, and we cool them down because we just think that they're overheated, but we don't think about the rhabdo until perhaps CK starts to rise. So why won't we see a CK rise early in rhabdo? Why don't we see it? Of damaged muscle. Why isn't that CK leaking into the serum straight away? Why isn't it? Why don't we see troponin rise straight away after a myocardial injury? Particularly when there is an occlusion. Anytime we have muscle or any tissue damage, what is the first step in tissue repair? Is it inflammation and increasing blood flow? Or is it hemostasis and stopping blood flow? What's first? Stopping blood flow. And so I've injured my muscle, I slow down and stop my blood flow, I have that reflex vasoconstrictive effect. Naturally, if no blood flow is coming into that muscle body, that further compounds the ischemic threat on that muscle, killing the muscle, widening the ischemic penumbra. There's a word you will use. Penumbra. And then when inflammation starts, some maybe 6 to 72 hours later, only then do we get that washout phenomena where all of those juices from the squeezed fruit now start to enter into the bloodstream and we see the elevation. So early rise in CK should not always be expected, and this is possibly why we don't see it immediately after crush injury. Certainly not immediately after the removal of whatever the crush is on that patient with rhabdo. There certainly was a lot of work done around that, but if I have to be brutally honest with you, it was the 2002 Bali bombing and the massive amount of muscle injury secondary we suddenly had a whole lot of research fodder. And and this was one of the issues with a lot of the response during the rescue of those that were survivors of Bali, was that we failed to recognise rhabdo early because we were worrying about other things. Yeah. So what's our assessment? Well, I mean, the key indicators still exist. So we're still looking at CK rise, and a mild elevation in CK is not necessarily diagnostic. bump my leg into a table and have a CK rise. I could go on a walk in a Vietnamese jungle and have a CK rise. But the sort of CK rise we're seeing with rhabdo, typically we're looking at 5 times, 10 times what would we consider to be baseline. On urinalysis, we may see it dipstick, and I'm hoping you understand what I mean by dipstick. Ward test, urine testing, positive for blood, yet not have any haemoglobin in it. Your dipsticks that you use clinically are incapable of determining myoglobin. Myoglobin looks almost identical to those dipsticks as haemoglobin. So when it tests positive for blood, it's myoglobin in the context of this discussion. Yeah? No red blood cells, necessarily. Electrolytes, of course, we're expecting all of the usual electrolyte rises, so you'll start to see phosphate levels rise, you'll see potassium levels rise. And as phosphate enters into the serum, phosphate's looking to scavenge up positively charged ions, and it does that with free calcium. So you should see a calcium level start to drop in this patient's blood as phosphate starts to bind with the calcium. Renally, this contributes to an acute kidney injury, so you'll see a reduction in glomerular filtration, and elevation, of course, in creatinine is going to be seen, and other funky abbreviations that you only ever look at when you're studying for an exam. The McMahon score is still relevant. It's been around for many years. And we're back. The McMahon score is still relevant. It looks at the age, and that's stratified with a scoring system from 0 to 3, from around about 50 up. There would be categories that get you close to a score of 3. I'm hoping I'm still in the 0-ish category there. Creatinine levels, again, that's graded through from a 0 to 3. We're looking at low calcium, high phosphate, as I've just said, and low bicarb, and we'll start to see initial CK rises. A person gets a score of 2 if they've got a CK rise of 40,000 plus. Remember what I said was normal was about 20 to 200. So 40,000 plus is not confusing. The picture of a huge CK rise like that is, well, this is the duck theory of diagnosis, isn't it? Looks like a duck. It quacks like a duck. It swims like a duck. It's more than likely going to be a duck. In the context of the history, this is more than likely going to be an event of rhabdo. So what are the pitfalls when we're assessing a patient? Well, assuming that muscle pain is benign. Muscle pain is often central to rhabdomyolysis. The pain is disproportional to the sort of pain that you'd expect from a given injury or a given crush. It's disproportionately high. Those that care for patients who have crush injury or rhabdomyolytic pain will experience the phenomena of having to keep going back to the locked cupboard to find more narcotics to give to the patient for whom the previous narcotics have not yet met their pain relief goals. So the disproportionately high amount of morphine that I have to give to someone, or fentanyl that I have to give to somebody, is almost diagnostic in and of itself. Relying on that classic triad. It's present in greater than 10%, but I had to throw that in for an end. Overlooking medications. Always have a look at the patient's medication sheet. Underestimating fluid requirements for these patients. We're going to do management very, very shortly. But fluid resuscitation becomes a very important and key part of this. If I want to protect those kidneys from being clogged up with myoglobin, I need to flush those kidneys. Now, there's 2 ways we can increase renal output. We can diurese them, or we can fluid load them. And the option we're always going to choose in this instance is fluid loading. So there's not a role for Lasix. There's not a role for mannitol. Certainly not first line. It's fluids first. It's about perfusing the glomerulus, not about making urine. Does that make sense? So the cornerstone for treatment is fluid management, fluid resuscitation. And it's aggressive. We're going to take the plants and water them. These are fruit that we have to water. So we're looking at 300 to 400 mils an hour. In fact, the strategy that's commonly used is not an arbitrary strategy like we might use with sepsis, where it's 10 to 20 mils per kilo or 30 mils per kilo. It's not an arbitrary value. It's a let's start aggressive fluid resuscitation with a crystalloid and then see what their urine response is looking like. And we are loading fluids in while we're watching this patient make urine, measuring their urine with an IDC, an indwelling catheter, looking for somewhere in the order of 3 mils per kilo per hour. Now, your normal urine output is 1.5 to 1 mil per kilo per hour. So we're looking at doubling to tripling what your urine output would normally be by blowing fluid through your kidneys. Yeah? So you think about a 70 kilo adult at 1 mil per kilo per hour, they're making 70 mils an hour. We're looking at chasing them up to 210 mils of urine output an hour. You're going to want a bluey. And doctors are going to need to learn how to use them. Are we still friends, doctors? Bicarb and mannitol are no longer recommended. The theory was that as myoglobin goes through the renal tubules, they combine with other proteins and they form casts. They form concretions on the inside of the nephrons, clogging the nephrons up, causing the kidney injury. And the formation of those casts is more difficult when urine has been alkalinized. So the theory of using bicarb was to alkalinize the urine to reduce the cast formation, thereby reducing the rate at which kidneys are going to clog. Great in theory, but a little bit like targeted temperature management in certain theatres of practice. It was not ever seen to be something that was really going to contribute to survivability. So it's certainly not considered to be first line. I've got two bosses in the room. One's watching the clock. Electrolyte management is all around those leaking juices, those leaking electrolytes. So when potassium leaks out, of course, that becomes a major problem from a cardiac toxicity point of view. Now, we've got lots of strategies to reduce somebody's potassium level. And so the question is, do I reduce the potassium or do I protect the heart from the potassium? Which am I going to choose first? Am I reducing somebody's potassium that's sitting at 8.1, or do I protect the person's heart from that potassium of 8? What's your priority? Protect the heart. And so the use of calcium, usually calcium gluconate in the circumstance, or if it really is very critical and you've got good IV access and you can go with a calcium chloride, triple the strength, then calcium's role in this is about protecting the heart from, as a cardiac membrane stabiliser, from the potassium, rather than having anything to do with the reduction of the potassium. What follows is going to be an insulin infusion with glucose to be able to, just like we talked about earlier, to reduce the serum potassium level and lock away that potassium back into cells. Hypocalcemia, therefore, is something that's going to correct itself when we give that calcium. And hyperphosphatemia really isn't that much of an issue because fluid resuscitation is offering a dilution. So we're getting a dilution with the hyperphosphatemia. Compartment syndrome is one of those areas that can act as a precursor, a major precursor. And when we have a patient that has a major orthopaedic injury, usually a long bone fracture in one of their lower or their upper limbs, then compartment syndrome can certainly contribute to a rhabdomyolysis. So rhabdomyolysis becomes secondary to the entrapped compartment. Remember the 7 Ps, and these 7 Ps play very much into the playbook of recognising compartment syndrome, but it's important to recognise that they can also be present in other forms of rhabdomyolysis where there wasn't a trauma or an injury that was the contributing factor. So the 7 Ps are the 2 pains. So pain on passive movement. We're going to put that limb through a passive movement. And if the patient has an increase in pain when we move their limb for them, that's got to be a tick in the bad book. Pain that is disproportionate for the type of injury. You know, this fractured tibia that you've looked after before, 1,000 fractured tibias in your life. And they all seem to be able to cope with about 7 to 10 milligrams of IV morphine, and they're in bliss land, they're in comfort zone. But this guy, he's soaked up already 20 milligrams of morphine and he's still climbing the walls. That has to be a red flag. Looking at things like pallor, paresthesia, looking at paralysis, does the patient have any numbness or tingling? Do they have any lack of active movement? And of course, very, very late signs in compartment syndrome would be loss of pulses. Loss of pulses is a muscle terminal sign. So what will we do with them? With significant rhabdomyolysis, this is first a cardiac threat, second a kidney threat. First a cardiac threat, second a kidney threat. And where it becomes a cardiac threat, it's fair and reasonable to have somebody on continuous monitoring. So it would be in a high dependency area that this person would be dispatched to, either in an emergency department with monitoring capacity or a high dependency unit, or at best, an intensive care unit. We want to be admitting anyone with a story that is suggestive of rhabdomyolysis and a CK over 10,000. Certainly anything over 10,000 would have to be suggestive of a cardiac threat. Anyone that's got a rising creatinine, so the creatinine that we took in ED, and then a few hours later when we did some biochem and we saw creatinine had significantly risen, then that would be an indicator. Hyperkalemia, of course, is our big red flag when it comes to rhabdomyolysis or any kind of muscle destruction. So we want to be looking very carefully at what somebody's potassium level's doing. And of course, anyone with a compartment syndrome, that would be a high index of suspicion that we should probably park that not on an orthopaedic ward, but in a place where monitoring is available. So after that marathon run, the guy that comes in a little bit dehydrated and a little bit hypothermic and a little bit muscle achy and a little bit sore, with a CK level of less than 5,000, then it's possibly fair and reasonable to consider sending them home with a increase your fluids kind of a story. So what is our takeaways? Well, it's going to be to recognise rhabdo early. Rhabdo kills because of the potassium hit first, and its secondary sequelae is renal. A positive urine test for blood on a simple dipstick, but the absence of red blood cells, is an absolute sign that there has been significant myoglobin leakage. Aggressive IV fluids are necessary, and when giving aggressive IV fluids, they're crystalloid based. There's nothing wrong with starting with normal saline, but after a couple of litres of normal saline, recognise the crossover to Ringer's lactate, or what we call Hartmann's at home, is probably going to be safer from a hypochloremic acidosis point of view. We don't want them having too much chloride. We've got to identify the cause, particularly if it's compartment syndrome or if it's drug-related. Bicarb and mannitol are not routinely used early anymore unless there is significant acidosis, where bicarb might be as secondary as it is in any other ALS type scenario. And monitor that potassium like your life and their life depends on it, because it does. Rhabdo. I'm done.
Anybody have any questions for Rob?
Okay, so lactate's only going to be elevated when the muscle itself becomes ischemic. So often the mechanism that causes the destruction of the muscle, of course, is a crush. So it's the crush injury that causes the muscle destruction, or it's a hypermetabolic state. The muscle is exhausted and it dies. It undergoes a process called autolysis, where the lysosomes burst open and hydrogen peroxide dissolves its intracellular membranes and the juice leaks out, right? Rhabdomyolysis occurs. It's different to an ischemic injury that causes the similar process of muscle destruction. And in an ischemic injury, first that ischemic muscle becomes anaerobic. And it's during that anaerobic process that lactate forms from the pyruvic acid, yeah? So now that lactate will start to rise. So if their rhabdo was caused from something that was an ischemic pathway, then you would expect to see an elevated lactate. Good question. I don't know the answer.
Anyone else? Excellent. You've got a big day ahead, Rob, so let's hear it one more time and relax. All right, we're going to roll straight into our final presentation of the day. So please make Luke feel nice and welcome as he comes up on stage. Thanks, Luke.
Thank you. Good morning. My name's Luke. I'm an emergency physician from Melbourne. I've been given the best job of the day as the introduction to lunch. I've got 3 speakers, or a multitude of speakers this morning to follow, that have all been excellent, but I'm going to take you to somewhere that you probably haven't been before. I'm not going to teach you any science. I'm going to share some experience that I hope you can think about and potentially advocate for and on our behalf in potentially difficult circumstances. We've got many Australians here, just a couple. How many of you have worked at a music festival? Anybody? Oh, a few. Excellent. Very good. So what I'm going to talk about this morning is the diminishing role and why it shouldn't be diminishing for doctors in the event medicine space. Where I am in Victoria, there's a lot of resource preservation that's going on, and event organisers don't like spending money. They don't think that there's a role for caring for their patrons. And so doctors are increasingly becoming replaced by paramedics, largely, and first aiders. And guess what? Sometimes it's just not enough. So what I want to look at this morning, well, every good presentation starts with a case, but our situation is that we're at a 5-day music festival, just north of Sydney. We're 30 k's though from the nearest regional hospital. We've got 15,000 attendees and staff to cater for, and around about 1,000 medical presentations, not including the first aid presentations, over a 5-day period. It's more than most regional emergency departments, busier than most metropolitan, out of metropolitan emergency departments. We see primary care. We've got 15,000 residents living in our festival grounds. We're also going to see some drug and alcohol presentations, and we're going to see some minor trauma. Great. Here it is. Out in the middle of the bush. This is what we have to play with. Okay? This is our waiting room. This is a bit of an idea about what's inside our clinic here. So these dividers sort of separate about 5 wards, if you like, that we run. We had actually a 30-bed facility that we were operating. Each of our wards sort of looks like this, with some camp stretchers and various equipment. Due to size constraints, we only allow 1 support person with every patient that we've got in care. This is our resus space, right? Temperature controlled, oxygen and other resuscitation equipment available, monitoring. We have the ability to do point of care blood testing, ultrasound and a variety of other things. And we have a patient. 25-year-old. Oh, they're healthy. Nothing wrong with them. Uh-oh. She has a history of hereditary angioedema. Anybody familiar with this? A couple. All right. Her triggers include respiratory viruses, pollens, and animal dander, and dust. what do we have in the Australian countryside that might trigger hereditary angioedema? All of it. Excellent. Uh-oh. She's been to ICU twice in the last 12 months, but fortunately she's never been intubated, maybe because nobody can. It's a dusty environment at the festival, as you might expect, and she's been out in the middle of it and now has a 2-hour history of tightness in her throat and some dysphonia. Any paramedics like to manage this one? She'd self-administered 2 doses of icatibant. For those not familiar with icatibant, it's very expensive. It's not given to just anybody, it's given to those that are the worst of the worst. And if she's had 2 doses of it and it's done nothing, we've got a problem. Right? It's usually not adrenaline responsive. That's a problem because our usual pre-hospital treatment for this is adrenaline. And if it's not going to respond to that, we haven't got a lot else. She's had no response or minimal response to self-treatment. She can't lie flat. But she's got normal vital signs. Ah, fabulous. So, what do? This sort of case presents a number of issues that we need to think about in the event medical space. The first is that healthcare is becoming a lot more complex. People are on medications and have conditions that have never been seen in the sort of rural environment or the event space before. And because we've got large populations at these residential events, we're starting to see more of them. And so we need to have a plan for how to manage them. We've got varying degrees of health literacy, which doesn't help. Some people understand their medical problems really well and can verbalise what their treatment plans are and how they work through their health problems. Some people can't even mention the name of their condition. They don't know what medications they take, and they haven't brought them to the festival. The procedural skill required with this sort of case needs expert level of knowledge. I was lucky. I'm an emergency physician. I had an anaesthetist colleague who happened to be working with me, so we had the right expertise to be able to manage this. The intensive care paramedic from New South Wales Ambulance, who was the ambulance commander for the event, didn't even know the pathology existed, much less didn't know what to do with it or what the implications were for his ambulance crew that were going to take it to hospital. All right? And so they, as an ambulance crew turning up, had no idea what to expect or what to do with it. And as part of that, we've got multiple layers of medical responder. So we've got everybody who's got a first aid certificate, all the way up to consultant physicians. You can't acquire experience by making experiments. People die if we experiment. So we have to have a plan. We have to go through it, we have to work it out. And so if you've got somebody who is working to a strict set of guidelines, they're not allowed to go outside their scope of practice, they have a very limited number of medications they can use, they're not going to have the right tools for every case. Some of you who are paramedics or nurses responding to the field will understand that you've got a rule book that you have to play by, and unfortunately, you're limited in that space. And this is where we come to the value of doctors. They've got a broad clinical experience. They have experience to some extent in diagnosis and definitive treatment, and that will depend on their type of training and the level of training that they've had. They've got a broader range of procedural skills and a wider range of pharmacotherapy that they can use. They're not limited by protocols and practice guidelines. This is not completely true. We still have to play by the medical textbook. But we can use our judgment to modify things to a greater extent than what nurses and paramedics can do. So some of the other situations that we find ourselves in, we do some rally car racing, we do music festivals, here's some of our setup, and this here is our 25-year-old with the medical retrieval team from Sydney that have come to pick her up and take her to Sydney. So she earned herself a ride in a helicopter to Sydney from the music festival. But not all doctors are equal. We have to be careful about this too. We've got to put the right doctor in the right place, right? And it's not just dependent on the quantity of time. A neurosurgeon with 20 years experience is probably not going to be terribly helpful helping Rob with his patient with rhabdo. What we find though is that people who have trained in the pre-hospital environment are more familiar with that space, more familiar with the drugs that we can use in that space safely. And whilst it has challenges, we find that we can provide better care to our patients in the event world. Training in emergency medicine covers most of the things that we're going to need, but as with this case, there are other critical care specialties that are quite useful as well. And on occasion, if I'd had an ophthalmologist working with me, I would have been quite happy about that too. We do have an emphasis, and a very strong emphasis, on multidisciplinary care. And this is important because it means that we can build bridges and we can strengthen relationships. How I see my patient, how the paramedic sees the same patient, how the critical care registered nurse sees the same patient, the three different opinions, three slightly different priorities, and we can share the cognitive and clinical load about caring for that person. So we certainly encourage having multidisciplinary teams as best as we can. How does this compare to the international experience? So from a music festival perspective, some of the largest music festivals, 400,000 attendees, across 6 independent sites, over 140 medical responders. I can't imagine working a team that size. That is huge, right? But they saw 12,500 patients in the week. What's interesting though is that their attendance rate was 3.1, or about 3%. So for mostly drug and alcohol type presentations, events that are going to have those sorts of risk factors, we see about a 3% attendance rate to health facilities. And that's fairly consistent across international boundaries and similar sorts of events. And that's per day. So if you've got a 5-day event, you're going to see 3% roughly per day for the duration of your event. Also interesting is the fact that it's about 6 to 8% require more than first aid. So they're the medical presentations, right? And about 13%, so a fairly high transport to hospital rate for these events, partly because these patients are going to need extended observation. And with that number of people presenting, you don't have a lot of time for each one. So shipping them to somewhere they can stay for a longer period of time is helpful. But you can imagine the burden on the local health service catering for that. So the more people we can keep at the event, the better for the surrounding health services. But it's not all music festivals. All right. This is from the Ryder Cup in 2023 in Italy. Interestingly, they had 60,000 people. There's plenty of people at a golf tournament. All right. It's lots. They were about a 1% presentation rate, which is a lower risk presentation. Nearly 50% of them required professional care. So that's 250 people to the local hospital if you don't put a doctor on site. That's a lot. Which hospital's going to cater for an extra 250 patients in 4 days? I don't know. Interestingly though, you put a doctor at the event and 80% of them can go back to the event, right? And that's because there's a large percentage of minor trauma, cardiovascular, so again they had point of care troponin testing and ECGs available at the event. They could clear people, send them back to the event. and that reduced significantly the burden on the local health service. Our experience is similar. The first aid will see about 2 to 3% of attendees per day for festivals. We see somewhere between 5 and 30% of the first aid presentations as medical patients, and about 10% get 10% of the patients that we transfer to hospital require critical care, which is not bad. We do put people in ICU from time to time. Motorsport, different sort of equation. So only 2% of the attendees require health service. So if you put 200 people on a racetrack, you'll see about 4 of them across the day, but all of them require professional clearance or treatment, okay? So if you don't have a doctor, that's 4 people to hospital. Okay, fine. So what we've got now is a risk assessment tool to decide when to send our doctors out, when our paramedics can be the lead caregivers, or if we send our nurses to a particular event. But we can offer this pathway to our event organisers and say, well, look, based on the risk and the number of people and so forth, we would recommend that you put a doctor at your event. We also provide this to local health services to say, okay, this is what we would normally do, and these are the things that we care about. This is emerging now into the disaster medicine space. If we have somewhere that's got a bushfire go through it or a flood, a certain number of people are displaced, how many of them are going to require healthcare? How many of them are going to need access to pharmaceuticals or have minor injuries resulted from the disaster? We can put it into here and work out what size team we need to send out. Principally, an event that is more than 50 kilometres from a responding health service is going to take a lot more time to get somebody to you. You have to be able to manage that patient for a longer period of time. Our field hospital can manage critical patients for upwards of 4 to 6 hours. Ventilated, inotropes, you name it, we can do it for that. We can monitor them with blood gases and so forth. If we're a long way away, we need to plan early to get people out because it's going to take a long time for transport to get to us. Residential events are interesting. It increases primary care attendance. And what we know is that emergency responders, particularly paramedics, although this is changing in some jurisdictions, don't have a lot of familiarity with primary care. And so for these ones, sending out our nurses with general practice experience or sending out some GPs to support the team as well can improve the quality of care that we provide in those settings. We know that our population is going to drive the number of people that are going to present to us. It's interesting that even if you have an event of only 5,000 people, which is quite small, the potential impact of having 15 to 45 that need professional care is quite a significant impact on local health resources. Even if only 3 of those need transfer to hospital, 3 can be absorbed in most places. But if it's a small country sort of hospital with the GP as servicing an emergency department, that might put even significant strain on them. We know that alcohol and other drugs, if they're present at the event, can increase our presentation rate from about 1% all the way up to 5%. 5 times the number of presentations just based on access to drugs or alcohol at an event. And that can increase your length of stay as well. And so making sure that you've got sufficient bed capacity to manage those patients and that they're going to stay for longer is an important consideration. Temperature is an emerging risk factor. There's new evidence in the pipeworks being written up at the moment that suggests that an event held in an ambient temperature with a low to medium humidity, if your temperature is above 23 degrees, even if it's indoors, your health presentations will spike. And so a lot of, this first came to prominence with some of the high rocks and other sort of indoor exercise activities. And we've got fairly good data saying the cut-off point's 23. So they set their air conditioners at 22 degrees. Perfect, we can cut down our medical team. As soon as you put it up to 23 or 24, you've got a problem. And finally, if you've got high impact or high stakes sport, this also increases the risk related to increased competitive nature of human beings. The amount of trauma that you're likely to see is going to increase as well. And so this is our assessment tool. If you hit any one of those markers, we will encourage the deployment of a doctor or a medical team to come to your event. So that's a bit about what we do. What I would encourage is, if you are part of an organisation that runs public events, that you think about the sorts of medical cover that you might have at such an event, that we try and mobilise politicians to increase funding. At the moment, we can't access government funding for any of the medical teams that we deploy. And it's all based and funded by the event that we attend, which obviously has an impact on ticket prices and attendance at those events. So if we could access government funding to support some of that, we would then be able to provide better patient care to the patients who attend these things. And also, to an extent, preserve public hospitals for the people that they're intended to serve, rather than for transient populations. Thank you.
Thank you very much, Luke. Quick question from me, because I've got the microphone. What are your thoughts on pill testing at festivals?
Yeah, it's an interesting one. The literature is very much supportive. Unfortunately, a lot of the literature is based in Europe and the American populations, and what we do know is that the Australian population particularly is more of a risk-taking culture than internationally. We do have some local experience that it is, in small numbers, reducing some of the consumption of known harmful substances. However, we've also had at pill testing sites some young attendees you say, "Oh, thanks for telling me that your substance is potentially deadly, I'm going to take it anyway." And a complete dismissal of what they've been told and the severity of the information that they've been given related to the pill that they've been had tested. There's the information in front of you. "Oh, it could kill you." "It's okay, I'll take my chance." And that's one of the changes or challenges that we see in events, is trying to deal with those mentalities as well, because then they become unwell. They might get, for example, hallucinations. They want to experience that, and they get grumpy at us if we try and take that away with some antipsychotic medications or things like that. So it's one of the interesting challenges we have in the event space.
Questions in the crowd? Rob, big voice.
Just a quick one around, how do you triage that many people? 4,000 people a day come through your door. How do you triage that? Conventional ATS triage?
Yeah, it is. Yep. But it's across multiple sites. So you might see, we don't have a 400,000 patient festival, but if we see, say, for example, 200 patients in a day, we might see on average 10 to 15 an hour, or one every 4 minutes. We could assign 2 triage clinicians to do a 30-second, 1-minute triage on each. And it's a very brutal triage process. It's look, see, oh yes, okay, you're walking. It does align somewhat to the trauma triage. You're walking, you can go over there, noting that people can walk in with serotonin syndrome and actually be quite unwell. So it's a little bit more complicated than that. But we're not sitting there doing blood pressures and temperatures on everybody. You get allocated to a space to start, and then re-triaged if it's later identified that you're sicker than you might have presented, or vice versa.
So going to one of the events, I've worked at Meredith Thank you, Dylan. And, you know, when you fill in your application to go to the festival, you often have to declare your medical background and anything like this. So I'm just thinking about that 25-year-old. Would have she been highlighted to the fact she may present to you so you are aware?
That would be amazing if it was and we try to push it with our event organisers that they do survey people on entry. For example, in motorsport, there's a very clear licensing requirement that their medical history is documented and so forth. Festivals, each organiser has their own methods. They each ask different questions. The majority, unfortunately, don't seek any health information. You could imagine at some of these places things like public health concerns are very important to us as well. We did a festival recently where we, unbeknownst to us, had patients attend with monkeypox exposure. And so having that come out of the woods, literally, was an experience we weren't expecting. And if you're not prepared for it, you can't do anything about it. You just say, I haven't got anything. But things, for example, like diabetes, just knowing that, okay, we've got 1,000 diabetics in the audience, I'm going to need to bring the insulin with me because they won't bring it themselves. It does help you plan, yes.
Hi, I have two questions. The first was, how easy is it to break into this sort of sphere? I'm an emergency doctor and I love festivals, but I guess I assume it's sort of people that do it every event, and it would be quite hard to get a gig if you weren't someone that did it regularly and was sort of a bit of an unknown. And then the second question is, who provides the medicines? Is it the event organisers, or do you have to bring your own little doctor's bag, or I don't know, I don't have anything like this. I work in a hospital, so...
Yeah. Where do you practice?
In Melbourne.
Excellent.
Outer Metro.
Then for you, it's very easy to get into this space. You come and talk to me later and I'll give you a job. It is very jurisdiction dependent. In Melbourne, where we are, there are currently 23 advanced providers. We have to have a licence as an organisation in Victoria to be able to provide this service. There are 23 such organisations in Victoria, which is lots, and as a result there is a lot of competition. Western Australia and South Australia are only just catching up in this space. They're a long, long way behind, and so there are only a handful of providers in each of those states, although Adelaide is rapidly exploding at the moment. Tasmania and Queensland have one or two providers each, so not very much competition there. Do you need anything? Generally speaking, no. It's generally provided by the organisation for whom you work. And the how to get there is merely to find an organisation that you want to work for and ask them to join up, okay? Jobs are easy to get for doctors. Not so much for paramedics, because we've got thousands of paramedics who want to work in this space. It's a lot harder to get in. But if you are keen to do it, there are opportunities. Nurses, yes. Nurses are an interesting problem for the system. Let me explain. Nurses, because of the way their profession is historically been created and set up, most nurses are in a situation where they have to require a doctor's prescription before they're able to administer medication. So unless you're working side by side with a doctor, you're often limited to working in the first aid part of the space rather than the medical space. A paramedic, in contrast, has a set of guidelines that they can work to, even if there's nobody to prescribe their medications. They're given a rule book by which they're allowed to administer certain substances. This is gradually changing, and there's been some movement in the space led by us, where we're saying well, nurses can read the rule book too. And what we're finding is now that the Department of Health that licenses us is becoming more agreeable to the idea of a nurse having fentanyl in their pocket and giving it to a patient, without a doctor's order if there's a need. That's taking some time to sort of change the mindset of politicians and bureaucrats to give our nurses some empowerment in this space. So it is coming, but it is a challenge at the moment. If you're in a full medical team, no problem. Can do anything, and nurses have a great range of scope that we can use in that space. But without a doctor present, still a bit on the border.
I'm just thinking with the country festivals, connectivity with regards to information sources, that you get your weird and wonderful, genetic diseases that, there's 3 of in, the world, and they rock up to you and your system goes down, and you've never seen it before.
We have a lot to thank for Elon Musk. Starlink internet is our saviour in that space, and a lot of still printed paper documents, access to books, particularly medication pharmacopoeias and things. Yep, so we have books. All of our documentation is done on paper for the most part. For those sorts of events, we do have electronic records, but they're susceptible to failure. So paper and pen is achievable. But things are a lot more accessible now that we have access to Starlink internet and those sorts of things. So even in the most remote places, we can generally get access to electronic resources.
Alrighty, let's hear it one more time for Luke. Very big thank you to all our presenters this morning. As per previous days, please join us for lunch or grab something for the road. Have a great afternoon. If you submitted a photo or won a t-shirt, come see Dylan or myself at the front. Otherwise, have a great day and we'll see you here tomorrow. Cheers.